Hi, this is Dr. John Bennett broadcasting from Miami Beach. Today we have the pleasure of having a well-known neurosurgery educator, is Chandra Deopujari from Mumbai, India. He's going to be talking about intraventricular tumors. And we have a diverse cast here. And let's go around the room and introduce everyone. We'll start with Dr. Cabulo. Good day, Dr. Cabulo.
Thank you so much, Dr. Bennett. I'm Dr. Cabulo from Democratic Republic of Congo. Currently, I'm a neurosurgery resident at the University of Zimbabwe under Professor Kalangu. I have my young brother who came for holiday, Dr. John. He can introduce himself.
Okay, I'm Dr. John from DRC Congo, general practitioner. I'm working in Lubumbashi town. I'm here in Zim to see my brother doing his master's in neurosurgery.
Okay, you're both very welcome. Ibrahim, could you please introduce yourself?
Hello. Hello, everyone. Hello, Dr. Deopujari. Thanks for your lecture for neuro residency and medical students. And I'm Ibrahim. I'm from Russia, and I will soon resident in Tumen Federal Center in Tumen of neurosurgery. Thanks you.
Very good. Dr. Deopujari, Ibrahim just won a contest in Tyumen for neurosurgical skills. And Dr. Deopujari has lectured in Tyumen. We televised him. Dr. Kestis, could you please introduce yourself?
Sure, John. I am Dr. Kestis Itsikevičius. Now I'm working as neurosurgeon in Lithuania in University Hospital in Klaipėda. So my main interest is skull-based surgery, ventricular surgery, endoscopic surgery. So that seems like in your presentations and webinar. It's nice to participate here.
Welcome, Dr. Kestis. Fabricio, welcome.
Hello. And where is Dr. Devra from?
Fabricio, could you tell us where you're from and what you're doing?
Hello. Hello.
Yeah, we can't hear you very well, but Dr. Fabricio's in Italy. We can't hear you very well. Can you, is your microphone okay?
Fabricio is not very well heard.
Okay, well, Fabricio's from Italy. He's a neurosurgical resident. Okay, Juma, could you please introduce yourself?
Hello, everyone. My name is Dr. Juma Magogo. I'm originally from Tanzania, but currently I'm in New Delhi, India, for my fellowship training in neurosurgery.
You're welcome.
Looking forward to.
Well, I'm very surprised to have so many friends on a Sunday, I must say.
Okay, very good. Harsh, could you please introduce yourself?
Hi, sir. Good afternoon. I am Dr. Harsh here. I am an assistant professor in Sanjay Gandhi Institute of Medical Sciences in Lucknow, India.
Great.
And incidentally, Dr. Deopujari was one of my quiz masters, and he has awarded me with the Young Neurosurgeon Award in India. So I am totally reverent to him. He has been my teacher in various lectures also, while I was doing a residency in Nemans, so I know him well.
Very good. Welcome, Harsh. Dr. Parthaban, could you please introduce yourself?
Yeah, hi. I'm Parthiban from India, neurosurgeon, interested in spinal surgery and, of course, skull base and microsurgery. A very good friend of Deopujari. Good to see you and like to see your lecture today. Yeah, John?
Very good. Very good. And the next panelist, please introduce yourself. Oh, let me go back to the speaker view here. I'm getting okay. Okay, let's see. Ali, could you please introduce yourself?
Hello again. I'm Ali Saad, medical student from Baghdad Medical School from Iraq.
Yeah, welcome, Ali, and he's going to be part of this team. Grant Sean, I don't know if you can hear me. Can you hear me? You would need to introduce yourself. Well, I don't think so. Okay, Dr. Deopujari, welcome and thank you for coming, and it's all yours.
Thanks. So what I thought of doing today is to really talk about a few aspects of intraventricular tumors, which from my personal experience, and probably emphasize on the endoscopic applications for tumor biopsies and the place of endoscopic resections during the course of this talk over the next few minutes. And good to see Parthik, one of the old friends. So I'll start off with showing you a few cases and talk about the various strategies. So basically, microsurgical strategies to intraventricular tumors critically depend on anatomic considerations to minimize the risk of injury to cortical, subcortical, and vascular structures. And though over the years we have found several sort of corridors to reach various parts of the ventricle where these tumors occur, I think endoscopic approaches have definitely added a new dimension to our way of approaching these lesions. So what can you actually do with endoscopic approaches? You can do right from biopsy of tumors under vision, drainage of cysts, relief of hydrocephalus by doing additional ETV, septostomy for aminoplasty, etc. Better assessment of spread. This is one application which I think is important from oncological point of view. It also allows devascularization of tumor by electrocoagulation of the pedicle in tumors like choroid plexus papilloma. Tumor excision may be possible directly, occasionally, or with endoscopic assisted surgery. And it also helps you to inspect for completeness of excision and making sure that there is good hemostasis. So chances of post-operative hemorrhage become much less. I'll start off with a case which is virtually inoperable. It's a biothalamic kind of a glioma. There's a patient I saw at the age of 11 months, almost I think more than 15 years ago. One of the first cases where what I planned to do was we wanted to take a biopsy, and we should communicate both the ventricles before we put a shunt so that we can manage this patient with a unilateral shunt. So this is how we go about it. You do a little lateral burr compared to what you would do for a ETV, and you start seeing the septum. And I'm first going ahead with performing a septostomy. The septostomy is usually done, I mean, depends on where the ventricles are most dilated, but it is safest to do it in the frontal horns, and therefore a little lateral approach is always better so that it can get you into that area. And you would coagulate if you encounter a lot of leash of vessels, but usually you can do it. The unipolar cautery probe is used without any power, and you make an opening into it, and then you dilate that opening either with a Fogarty balloon, or usually I like to put the scope through it, and that usually takes care of making the opening at least 3 to 4 centimeters. Thereafter, the next job, of course, is to take a biopsy, and this biopsy in this patient proved to be a low-grade glioma. This patient was observed for about 3 years or so, when he managed to do well on just a shunt, and we did not do anything for the tumor. And at the end of 4 years or so, the oncologist decided that the child should probably have radiation. And thereafter, for several years, till the child was under follow-up, the child developed reasonably well, though I have lost follow-up for last few years. This is another patient. This is an exophytic hypothalamic glioma, and this patient has come with unilateral visual problems as well as hydrocephalus. So one of the colleagues elsewhere has put in a shunt, and this patient, when he is presented to me, he has come in a situation that one ventricle is drained, the other ventricle is not drained, and we still don't have a definite diagnosis on this patient. Though many hypothalamic gliomas in young age can be treated without a histopathological confirmation, the oncologist felt that if we are going back again, we should probably try a biopsy. So we went ahead, and we performed a septostomy like the earlier patient. And then I also went ahead and did a biopsy. This showed it to be a pilocytic astrocytoma, and this patient underwent radiation therapy, and for last 7 years or so he has remained stable since then, as you can see on this post-operative scan. The advantages of endoscopic tumor biopsy are, of course, that it can be done under direct vision. You can get a larger specimen. You have to, of course, use bigger forceps like deck forceps to get a larger piece of tumor rather than what is available with the smaller endoscopes. The bleeding can be controlled well with your hemostatic strategies. And if favorable, you can proceed for tumor excision depending on the vascularity and the extent of the tumor, and you can simultaneously do endoscopic third ventriculostomy if it is required. And I think the safety and diagnostic accuracy of endoscopic biopsies was actually quite well described in this paper published in 2013, which was commissioned by the International Federation of Neuroendoscopy, where several centers joined in and pooled their experience of more than 165 cases and seem to be giving very favorable results. What do you do with a posterior third ventricular tumor? So this is one of our recent patients, and here I think today we have a very good protocol, probably accepted internationally, that if you have a third ventricular tumor with hydrocephalus, you would probably proceed to endoscopic third ventriculostomy to relieve the hydrocephalus and do the biopsy at the same time. It also gives you an opportunity to examine the CSF for tumor markers and malignant cells. And then if the tumor is radiosensitive, you proceed for radiotherapy. If the tumor is radio-resistant, then you have a choice between surgery, chemotherapy, or if you decide to, sometimes you decide to just wait on the patient in very low-grade gliomas in the tectal area. And if you do not have hydrocephalus, then of course you have to resort to microsurgery, though there are certain papers coming up which say that you could perform endoscopic resections even in normal sized ventricles. So this patient with this posterior third ventricular tumor underwent biopsy, as you will see here. You can see that there is a small seedling here in the floor of the third ventricle, and then the third ventricular floor is not usually translucent as usual, but though it is opaque, you can probably see the third nerve and the basal artery to some extent, and an opening is being made, and then the balloon is being placed, and you can see the prepontine space quite well. Then we go ahead, and this is the tumor obstructing the aqueduct, and biopsy is being taken. This turned out to be a pilocytic astrocytoma, and then this patient's shunt hub was blocked, which was performed elsewhere. So we've actually retrieved the shunt at the same time. There are some technical issues while performing this kind of a procedure. You should probably do either two burr-holes, one for the regular ETV and one for biopsy, which should be anteriorly placed, or you can occasionally manage with one ventricle if the size of the ventricle is large and if the massa intermedia is not thick. Posterior burr-hole is used usually for ETV, while a hairline burr-hole is preferred for biopsy. And if you decide to do a single burr-hole, then it should lie somewhere in between. There is also a debate about what should be done first, ETV or biopsy, and it stands to reason that ETV is done first so that your vision is not obscured by bleeding, and then you follow it up with a biopsy. So this is another patient. The patient has a pineal region mass representing likely pineal tumor, and this patient, as you can see, has undergone a third ventriculostomy. I think this is at a stage where third ventriculostomy is probably already performed. You can again see that this kind of a deposit, which you are seeing here, is not usually seen when on the MR itself. We saw the preoperative MRI, we could not find it, but as there was no biopsy available, we went ahead and removed a part of this seedling, as well as we went ahead and removed the biopsy from the main mass, and this turned out to be a pineal parenchymal tumor, and this patient underwent surgery and radiation. Another patient with a germ cell tumor, you can see this. There is a little bit of meningeal enhancement. The biopsy proved it to be a germinoma, but more importantly, what you would find is that there are several seedlings which are actually blocking the third ventricular floor. And though third ventriculostomy could be performed in this patient, patient was immediately taken for chemotherapy, and after 6 cycles of chemotherapy, the patient had a good remission. But basically, for staging the disease also, endoscopy is very helpful to show you the CSF seedlings which are not otherwise visible. Colloid cyst is one application where the endoscopic application can be curative. You start off with coagulating the choroid plexus attachment, and then you make a decompression, and then you can cut off the and get rid of the cyst. Doesn't always happen because sometimes the venous confluence can bleed, and that can be quite difficult to control. And therefore, this is something which you need to be very experienced with, and you should know where exactly to make the cut so that you don't get into trouble. Occasionally, you may be able to convert it and stop the bleeding, or it can stop with irrigation alone. So I think this is an indication which should be left to people who do this regularly. It should not be something where you are starting out endoscopy with a excision of colloid cyst. One of the other applications which we have found quite useful is for a neurocysticercus granuloma. So a neurocysticercus is something which you would find in India occasionally, more common of course in South America, as most of you know. And here is one neurocysticercus cyst which has formed a granuloma at the level of the foramen of Monro. And this is what we are looking at through the endoscope. And then this cyst could be completely excised, having some problems here.
Okay, you're having problems sharing the screen?
So shall I go back to share?
Yeah, sure. Yeah, go back to share. Just simply go back.
Okay. So I come back to my first slide then, and what I will do is
just skip ahead.
Get on to where I was a moment ago.
Okay.
So
there you go. Procot. Okay.
Can you see it at all?
Yes,
no.
Procot. Procot. We see the slide P-R-A-C-O-T, cot. Procot. Can you see it?
Okay, yes. So this is at the end of the procedure. You can see that the foramen of Monro is unblocked. You have normal sized ventricles, and the patient has recovered quite well from this kind of surgery. And this is actually another patient with multiple neurocysticercus, which I actually operated at Sanjay Gandhi Institute, where Dr. Devra is from. And we could manage to remove 3 cysts from here, and thereafter the patient has managed to do quite well. This is the post-operative picture here for you. Now, other cystic lesions which can probably be treated are one of them is craniopharyngioma, and there is an increasing tendency when you have a lesion which is more into the ventricle, more into the third ventricle. You can do a burr hole and probably not only aspirate, but try to remove this tumor. And this is the tumor I started off many years ago, thinking that I'll probably drain out some cysts and it will make it easier for me probably to do a radical excision later on. But in this particular patient, actually the cyst collapsed very nicely, and doing a small mini craniotomy, which was already done by an earlier surgeon, I could remove this cyst almost completely, and which gave this patient a radical excision at the end of this procedure itself. This is how you can keep on communicating various cysts and draining them, and then reducing the size of the cyst, and you can see the normal ependyma surrounding it. Another lesion which we have been able to remove during this is a avascular lesion like an epidermoid cyst. So this is a lesion in the posterior third ventricle, and here we first went ahead and did a third ventriculostomy, and then this was followed. This is the opening of the third ventriculostomy, and then this was followed by looking backwards. That's the end of the third ventricle, and this is where you find this epidermoid cyst, and this can be very easily broken with tumor forceps and gradually removed with copious irrigation. This is the post-operative scan which shows that it could be removed completely. What about large solid tumors like this? This is a 1.5 years old child. The grandparents noticed that the child wasn't walking very well as he used to previously, and therefore a scan was ordered. This patient is symptomatic for the tumor as well as for the hydrocephalus, and in such cases we thought we should take a biopsy. There was no visual complaints at all, and therefore we did a septostomy, we did a biopsy, and we were thinking of putting in a unilateral shunt, but the report came back as pilocytic astrocytoma. So we went ahead for an excision, and with a microscopic assisted excision, and we could manage to remove this tumor almost completely. This is about 8 years ago, and the child has done quite well since. This is another patient. You have a small lesion in the frontal horn here, and therefore once you know what trajectory, and for trajectory it is very useful to have a navigation which is being used in this patient. So you come at a trajectory where you can remove this tumor completely. This can only be removed if you come at this trajectory, and therefore the trajectory is more important in these kind of surgeries, so that you can manage to get these lesions out, and this has been possible to remove the lesion completely. This is one of the recent patients, 18-year-old girl presenting with headache and diplopia, and this is what you see on her MRI. You can see that there is the third ventricle seems to be obliterated, and you can see the ventricular dilatation, and this is another picture which again shows periventricular lucency, and we go ahead for an endoscopic procedure in this patient, and you can see the choroid plexus, you can see the lesion. It is a relatively avascular lesion which is first being biopsied. Biopsy showed this to be a subependymoma. So we went ahead and started removing this lesion, and this is the instrument which we have started using recently. This is a cavitron which can be passed through the endoscopic channel. This is the equipment. There are a couple of them available. This is the one made by Zuring company, which we have started using, and we get gradual debulking, and eventually we manage to excise this lesion completely. And with a lesion like subependymoma, this is a completely curative excision in this particular patient, and this is a 3 months post-op MRI, which shows you that the lesion has been completely excised without any cortical damage. This is another view of the same patient. So endoscopic cavitron is being used. A side cutting device is available from Nicomed for quite some time, but I think they don't sell outside United States. And the Zuring device is a device being made in Germany, which is being used in Europe, and some of us are using it in India as well. So this is another patient where we managed to remove this. This is a pilocytic astrocytoma, exophytic into the middle of the third ventricle, more like a thalamic exophytic lesion presenting with raised intracranial pressure. And this patient also had a shunt done, but did not have a definite tumor surgery done. So this is being opened. You can start seeing the lesion now. It has some cystic areas, but mostly solid. So we went ahead, did a third ventriculostomy first, and then we started removing the tumor. This is the biopsy being done. and then the CUSA comes into picture. And you can see that very gradual rotations of the CUSA, they can take out chunks of this tumor, and this is a fairly good device which can be used. I think it is such a tiny device that it can get repeatedly clogged, and therefore it can be tricky at times to use it, but it is very useful to gradually remove this tumor. And this is the post-operative scan showing a good clearance. So when can we actually use this? Can we use it only when the patient has large ventricles? And people have studied this, and actually Mark Sweden very strongly feels that even without significant hydrocephalus, their accuracy of getting tumor biopsy has been quite good. Tumor resection is another matter, but they have shown almost 92% excision rate in well, 92% in the general series, but almost 100% excision in the 3 patients they have attempted without hydrocephalus. I am still a bit reluctant to use only endoscopic method in patients who have no ventricular dilatation. Another important application of endoscopy, of course, is hypothalamic hamartoma. And I think you can do it through either interfornicial approach or transforaminal approach. But the main idea of this is probably to disconnect it from the ventricular wall and the mammillary body. And that can be very satisfactorily achieved. If you have a good control, you can see here the hamartoma on one side, and this has been completely disconnected by using just our regular biopsy forceps. In choroid plexus papilloma, especially when the ventricles are large, I have found it useful mainly to coagulate the pedicle before we start, and then we go ahead and remove the tumor with microscopic assistance. And then again towards the end of the procedure, it becomes much easier if I can use endoscopy to make sure that the bleeding has stopped from everywhere. We have removed the whole tumor and there are no open blood vessels, so that you can breathe easy and sleep easy after surgery, and there is usually no need to keep a ventricular drain at the end of this surgery. What about neurocytomas? I think neurocytomas are mainly solid tumor. Occasionally they can be very vascular, and it may not be very easy. This kind of a tumor, which is partly exophytic, the best way is probably to treat it with a microsurgical method, which is what we are doing here. I usually like to do transcortical surgery when the lesion is coming exophytic into the subependymal and subcortical area. If the lesion is entirely free from the roof of the ventricle, then you can probably try a transcallosal approach, which is equally good and some people feel is less traumatic. What is the use of endoscope in this kind of a bloody surgery in a large tumor? I think though we have removed the tumor completely, I really can't watch everything that it has been cleared and there is no hemorrhage. So again, I'm using this mainly to inspect the cavity to make sure that I have removed the whole tumor and there are no major blood clots and there is no active bleeding point in this kind of a patient. And this is the post-operative picture after about 6 months of surgery in this patient, showing a complete excision. Nowadays, actually, we are using bilateral or biportal entry for craniopharyngiomas. We usually remove as much as possible in this kind of a patient. This is a boy who came in a very bad state of not only visual problems but raised ICP, and we drained this cyst, left a catheter there. The child got better over the next 2 or 3 days with hormone supplements and drainage of this cyst, and then we went ahead and did a transnasal surgery where we managed to get this tumor out almost completely, and you can actually see the catheter at the end of it, and this is after the clearance. And we recently published this in Child's Nervous System, about 20 patients done in this kind of a manner. Another way you can use endoscopy in third ventricular tumors is illustrated in this particular case. This is a 25-year-old girl who presented with headaches and visual blurring. You can see that she has hydrocephalus with periventricular lucency, and you can see a lesion in the posterior third ventricle. Once you see the diffusion restriction, you know for sure that this is a epidermoid cyst. And in this particular patient, we thought that the best way to get this lesion out completely would be to go through the supracerebellar approach. So this is a patient, this is the top, this is the bottom, the cerebel is being uh, pushed down or pulled down only with the bipolar forceps. Under microscope, you're starting to see the posterior fossa, the quadrigeminal cistern cyst, and it is gradually coming out with microscopic methods. So the suction and the tumor forceps is working between the various layers of dura to remove this arachnoid, to remove this tumor, and we're trying to remove this as completely as possible without putting a retractor, without ligating or coagulating any veins, which is very, very crucial in this kind of a surgery. There is a large vein in the middle which you can see now, and we don't want to disturb it. So at this stage, we think that we probably may not be able to remove very much unless we retract further. And rather than retracting further, we decide to probably change the angle of vision and maybe use endoscope to remove if there is any further tumor remaining. And this will be seen very shortly. You can see that at the floor, we are seeing some cyst still there. So an endoscope goes in at this time, and the suction goes in along with it, and this part of the cyst is being removed from the quadrigeminal plate, and it's being gently pulled out of the veins. Another piece coming out. And with irrigation and suction, this can be virtually completely cleared, and you can see the aqueduct opening now and the CSF flow being completely established. The inside of the third ventricle looks quite clean now. So is the surface of the quadrigeminal plate, and that takes care of the whole surgery, and the whole lesion has been removed here. So I feel that endoscopic surgery has not obviously replaced microscopic surgery, but it can minimize your surgical approach. It can probably give you a clue as to what is the best way to treat this patient by doing biopsy. It can help you to relieve hydrocephalus by doing a septostomy, a third ventriculostomy, and it can also help you occasionally to remove the tumor completely. And I have not shown our own experience, but I think I have probably a few cases. Over the last 15 years, we have operated on 272 patients, and 84 of them have been children. And we have found endoscopy useful in about 81 of these patients. So this is the summary of our experience, and where we think the endoscopic methodology can be useful in intraventricular tumors. There are, of course, certain surgeons who find a greater percentage of tumors can be resected, but I reserve my judgment on that, because I think it depends on what kind of accuracy you get, what kind of experience you have, and things like micromanipulators, etc., where you can actually do two-hand surgery in intraventricular surgery. Right now, two-hand surgery in intraventricular surgery by endoscopic method is not really feasible for most of us. And I think that would probably change the picture in future. But this is where it stands as of now, in my opinion. Thank you.
Okay,
I'll be
very good. Excellent, Dr. Deopujari. Before we turn it over and ask some questions, I wanted to introduce you to other people that have come, just to show the diverse audience that you're attracting. Amira, could you please say hello to Dr. Deopujari?
Yes, of course. Hello, everybody. I can't see anyone.
Yeah, we can hear you. Go ahead.
Hello, everybody. Thank you, Dr. Deopujari, and thank you, Mr. John. Thank you, everybody. A wonderful presentation.
Okay, very good. Welcome, Amir.
Thank you.
Okay, Dr. Deopujari, you can get off the screen share by clicking on the top of the screen. It says stop screen share.
Okay.
Okay, just go to the top of your screen. It says stop screen share. Very good. Warlux, could you please introduce yourself to Dr. Deopujari? Unmute yourself, please. We can't hear you. You got to unmute. Okay, go ahead.
Okay.
You're muted.
Yeah.
Can you hear you? Go ahead, Warlux. Go ahead.
Okay. Hi. That's I quite like come late a little bit, but that's amazing presentations. Thank you.
Okay, welcome. Abdul, welcome. Could you introduce yourself to Dr. Deopujari?
Hello, everybody. I'm Abdul. I'm from Africa, and I'm a neurosurgeon.
You're from the Ivory Coast, right, Abdul?
Yes.
Very good. Welcome, Abdul.
Yeah, thank you.
Gansham, could you please introduce yourself to Dr. Deopujari? You're muted at Gansham. Just unmute yourself there.
Hello. I'm so thankful. I'm feeling so great to be over here with you and Mr. Dev. Really, it's extremely the most important aspect of the neurosurgery to have the intraventricular intervention. I'm the basically consultant neurosurgeon in the Kingdom of Saudi Arabia. Hello.
Hello.
Mr. John, you're listening.
Yes,
Hello,
please
Mr.
introduce yourself, please. We'll get to the questions after.
Sorry, this is Dr. Das from basically Kingdom of Saudi Arabia, King Saud Hospital from Riyadh. And I am the firstly, I'm listening this really precious, this meeting. And I'm so thankful to Mr. John who made it possible. And I'm really thankful to Dr. Deos who made it really. I'm thankful to share, to have this extraordinary experience, the golden experience, and really learned a lot. Thank you, Mr. Dev, and thank you, Mr. John.
Okay, Gansham, very good. Welcome, and you're welcome to all the presentations. Jitin, welcome. Could you please introduce yourself to Dr. Deopujari?
But go ahead, Jatin. Let other people also hear.
Go ahead, Jatin.
Good evening, sir. How are you? Good evening, sir. I'm fine. How are you? Good evening, Dr. John. Thanks for inviting me. Sorry, I could join it very late. Actually, I'm traveling. Hello, can you hear me?
Yes, we can hear you, Jitin.
Hello.
Yes,
heard my talk before.
Yeah. Thank you, sir. Thank you very much.
Okay, Panam Palan, I can't. Can you please introduce yourself? You're muted. You're muted. Unmute yourself. There you go. Okay, go ahead.
I'm from Sri Lanka. I have just joined this forum from last week. I'm a neurosurgeon. I'm in National Hospital of Sri Lanka. I'm just starting my consultancy. So after my training in UK, and I'm interested in skull base and vascular part and the spine surgery also. Yeah. So we have to do almost all the surgeries, and nice to see you all giving these very useful, precise techniques and these. And nice to see for the young surgeons like us to see this sort of experience, and it gives us a lot of confidence to proceed with the endoscope. Thank you.
Great. It's great to have Sri Lanka here on the panel. Okay, I guess we'll open it up now for comments or questions of Dr. Deopujari.
Yes, Jatin, you have
Go ahead. Go ahead, anyone.
Can I ask, sir? Hello. Hello. Sir, what is the incidence of postoperative fever in after your interventricular tumor surgeries? And how do you deal with it?
haven't particularly looked at this separately, but it has not been very significant. Wherever there has been some intraventricular hemorrhage, you get some amount of fever, and this you see also in some craniopharyngioma and epidermoid surgery because of the chemical reaction. But I don't think we have seen something which is only because of the intraventricular location of the tumor. If you're asking that, one of the reasons may also be because in my earlier part of my series, I have been keeping drains for first 24 hours in every patient and then removing them only after they have had a check scan at 24 hours. So maybe that drains out some blood, which I think is probably responsible for the kind of fever you are talking about.
And sir, apart from the tumor surgeries like epilepsy surgeries, in those patients, sir, suppose
you are absolutely right. Somehow the incidence of fever is much higher in epilepsy surgery like hemispherotomy or corpus callosotomy. You get much higher incidence of fever. I do not know how does this work.
Thank you, sir.
Okay,
Thank you,
any more questions,
Hi,
comments for Dr. Deopujari? Go ahead.
Yes. Hello, Dr. Deopujari. I want to ask, what if you encounter a bleeding? How do you come to control the bleeding through ETV?
I think it can be very frustrating when you have bleeding in intraventricular surgery, and if you are doing an exclusive endoscopic surgery, and many a times you feel like just giving up and converting to microscopic surgery. That doesn't make your job any easier, but you can maybe retract better, etc. I think the only way to make sure is to just continue to irrigate, and most of the times with irrigation, the bleeding usually stops. I have had problems with bleeding where I have converted to microscope. One is when I did not feel confident enough to coagulate the veins, at the venous angle near the foramen of Monroe, because I don't want to sacrifice those veins. And those are situations where I get a venous bleeding. I would just continue to irrigate, not use coagulation at all. And the other is if you get an intraventricular bleeding, like happened recently in one of our patients, the intraventricular bleeding was just uncontrollable, and in such patient then we converted to microsurgery and excise the tumor rather than stopping with only biopsy.
Very good.
Thank you, sir.
More questions or comments from the panel?
Yeah, comment. Can I give one comment?
Yes, yes, of course.
It's very nice to see Dr. Deopujari's talk. It's absolutely fantastic. And me as being one of his friends, and I know the commitment he has made for endoscopy. The point which he made for choroid cysts is amazing. And that's one thing is really very, very supportive to young generations. The point which he made that the venous bleed need to be patiently waited and saline wash. I had a chance to do some surgeries with Ortel, Jokamata, and he was also telling the same thing. So the dissection at that region is more critical, and that point is well made by Professor Deopujari. Excellent. That's a one point, because there was a time when it was surging up that all colloid cysts need to be operated by endoscopy. Now, Professor Deopujari's experience is beautiful demonstration of the case, and I really appreciate. Thank you, Professor Deo, my friend. Thank you.
Thank you for coming. Okay, more questions or comments for Dr. Deopujari?
Sir.
Yes, go ahead.
Sir, I would like to ask, has anybody, I mean, it is open to the panel, has anybody had experience with the exoscope, the new 3D exoscope that Zeiss has introduced, which integrates the endoscope with the microscope? I suppose that is one of the new things that has come in.
I have seen people operating. I have not operated myself yet. I'm hoping to get some exposure to it when our turn for getting the exoscope comes to our theater. But I have personal experience of operating, though I have seen some very good surgeons operating with exoscope and doing a very good job. I think the depth of focus remains a problem. And unless you have, most of these have, digital zoom and digital focus, and occasionally it can be a problem when you are working at depth. But I think for any superficial lesion, I am not sure if it is a good equipment to use for intraventricular tumors. But I think for regular microsurgical lesions, for cortical, subcortical lesions, surface meningiomas, exoscope is excellent.
Okay, very good. Further comments or questions? Dr. Kabulo, do you have any comments or questions for Dr. Deopujari? Unmute yourself there, Dr. Kabulo.
Yeah, I say this was an excellent presentation. Currently, I don't have a question.
Okay, very good, Dr. Kabulo. Thank you.
Welcome.
Abdul, do you have any comments or questions?
Fine.
I have a question.
Fine, yes.
Go ahead. Go ahead.
Okay. In children, when we are doing endoscopic procedures, do you maintain a pressure level? Now when we put the irrigations, do you maintain a particular pressure level, or is you maintain the same level as an adult?
So basically, the pressure is maintained by the natural outflow. You do not block the outflow. There are very few occasions when you want to block the outflow for a few seconds maybe. But on a regular basis, you have an irrigating channel and you have a channel for the fluid to come out. So the pressure is maintained by, the pressure is maintained by the natural forces. You do not try to interfere with it.
Okay, very good. Okay, further comments or questions from the panel? Fabricio, any comments or questions?
I have a question. First of all, the presentation was very, very interesting. My question is the percentage of lipofistula.
Sorry, come again.
The percentage of lipofistula.
CSF fistulas. CSF fistulas at the level of entry, where you enter the ventricle. Right, I think that's a very, very good question. I think it can be a really big problem in very small children, that the endoscopy tract does not close so easily. If you really have a large hydrocephalus, and especially in small children who have thin scalp, it can be a problem. So we have a few ways of dealing with it. If we feel everything is clean, we would probably plug the hole with, you make like a cigarette of gel foam, plug the hole and put a few drops of glue in it. And that has worked reasonably well. The other thing is, you try to suture the dura. If the children are very small, try to close the dura. So rather than making a small burr hole, you would like to make a larger burr hole or a mini craniotomy so that you can close the dura. These are the two ways. The third way, which we have occasionally chosen, if there has been bleeding or if we are worried about, the status at the end of the surgery, we usually leave a reservoir, ventricular reservoir with Ommaya-like chamber, and then we remove this subsequently when the need for that has been obviated, or in some cases, if it continues to collect, then you may consider doing some kind of shunt, subdural or ventricular shunt. We have only 2 occasions where we had to put subduroperitoneal shunts, and we have had 1 occasion when we had to go back to plug the hole because it would just not close. But apart from these 3 patients which require specific action for the tract problem, tract CSF drainage, fortunately it has the methods which we are using worked out reasonably well. But there have been 3 second surgeries for CSF tracking.
Okay, thank you, Dr. Deopujari. Any further comments or questions for Dr. Deopujari? Okay. Okay, Dr. Deopujari, thank you very much. As you can see, you attracted a wide audience from many places.
Thanks, John. I think really a good job. I think quite a few people are getting interested. And I thank you for the opportunity and wonderful moderation.
Okay, very good. We welcome you to have further presentations whenever you're ready. And thank you for all the panelists. We'll wrap this up formally. We're waiting for Iype Cherian to come in to do his presentation. And so, okay, we'll formally stop. Thank you very much for coming.